This conference will now be recorded.
All right, so this is Journal Club for March 24th. The article I chose is actually a different article than I had originally planned, but on the same kind of topic. Um, my title is Machine Learning and How Can It Improve Amid EMS, basically. The article's below it. It's a validation of machine learning-based risk scores in the pre-hospital setting from 2019. This is me. So just a disclaimer, I'm not an expert at machine learning and artificial intelligence by any stretch of the imagination. And that's one of the reasons I picked this topic, is to kind of improve my understanding of it. So I have a couple slides on just a quick primer, very bare bones and very basics. And I'm sure other people on this either know more than I do or have friends that know more than I do, but it's relevant just to have the couple points that are relevant to the article. So machine learning is an overarching term under like artificial intelligence. They're kind of two separate things. A lot of the times they get lumped into one topic, but they're actually different. Machine learning specifically is all different types of learning and all of these types of learning that kind of make up for it. And each part of this is a step in the process to get to a general outcome. You input data, you go through these different steps, and then you get an output. And whatever that output is like, game AI or estimating life expectancy or something like that. So there's a lot of different portions of this. Essentially, this is how it works. And there's other pictures that kind of say that it basically mimics a brain. This is a neural network, which is a part of machine learning. And basically, you put inputs in your hidden layers are basically nodes and criteria for what part of the input should be part of the output. So it'll kind of make a little bit more sense in a minute, but you're basically trying to define what truth is in your input. So you can put however much you want in, and then you define what of that noise that you actually want and what's actually real to become your output. And it goes through various layers, and you keep training it and reinforcing certain things, and that's how you get to the actual truth of what you want. It's essentially trying to mimic what we do on a daily basis. We have inputs from sensory and environmental and from our education, and we go through all of these different pruning in our brains, and then we have an output of this is how you see the world and this is what you see. And for medicine specifically, it's how your training was, the things that you've seen during your career, and then this is how you basically assess your patients. So I bring this up because this is coming to emergency medicine in general. It's already in emergency medicine. It's already in radiology. When I was in residency, they were using an artificial intelligence mapping service and a neural network to define large vessel occlusions by software before the neuroradiologist even saw the images. They are working on various kiosks that you basically, when you come into the ER, you input your symptoms, it brings you down an algorithm, and then it triages you based on that, and then kind of spits something out for the ER doctor to chase. It's very all in infancy, but it's definitely been talked about for at least 5 years that I'm aware of, if not longer. And it's coming to emergency medicine services. And there's a couple articles in here that I almost picked for this journal club, but there were so many that I'm just kind of highlighting. Out of hospital cardiac arrest data. That's a huge one that you're going to see. The first one was linking, just records, making sure that you can, the patient that you brought by 3242 is the same patient that showed up at NBI. That's the same patient that was discharged 3 days later, a week later that day. This was the original one that I was going to do, which Navin sent me, was machine learning based dispatch for drone delivery. I was going to try to make this a two-part, but it was a lot more detailed than I planned. And that might be for my journal club in June, or if somebody else wants to do it. But essentially they looked at using machine learning from dispatch criteria, EMS criteria, and transport criteria to determine if a defibrillator could be it could be brought to the patient and the right patient with the right amount of specificity and sensitivity to make sure that you were not short on drones when you really needed it, and you were delivering them to the patient that really did need it, which is a fine line. So it's an interesting article that I think would be worth looking at in the future, because again, this is coming. Maybe not necessarily Newark, but it's coming to EMS. Hybrid simulation models by machine learning. Another one based on ambulance demand. Like, so if we think about FirstNet, which I know that we use in our dispatch center, JFK uses in theirs, part of what some of their software offerings are to predict demand, and so that you can post trucks in certain areas or flex up or flex down, and based on that information, and machine learning is one of those ways. This is another one that this was mainly based in the ER, but acuity and triage, which kind of comes into what we're going to talk about today. So our PICO questions. The study was in Sweden, so already you could say it's not 100% relatable to all of our population, but it's definitely, the use of it in Sweden is because they have a centralized EHR. Steenberg could probably talk a little bit more about that from his time in like Switzerland and everything, but in general, a lot of these other countries have a general EHR, or they have a population-based system where even though you don't go to the same hospital, you can find the data very easily. Specifically, this city was used, the population was about 376,000. They used 2 hospital-based ERs. The ambulances were staffed with nurses, and the dispatch center had a nurse in it. So again, it's somewhat relatable. We do have MICNs on the trucks here in New Jersey, but it's not relatable necessarily to everywhere else. And this has to do with the assessment of the patient. So what they did is they looked at dispatch data, ambulance data, and hospital outcome data. And the way they pulled it from 2016 to beginning of 2016 to the end of 2017, and then they tested it in 2018. And it sounds like a lot of information, but they basically just pulled every single possible record that they could, matched them all up, and then started training their software. And every single patient was included, except for what's down here. So anybody under 18, if they were missing more than 2 vital signs, if it was more than 1 patient, so you went to a car accident and there were 2 patients, if you were canceled, if you were treated and released, or you were unable to find the hospital data or alternative destinations. So if they were brought to an urgent care or primary care clinic, that wasn't included. So there's, again, this is more of a pilot study. And under 18, they can't determine a news score, which we'll talk about in a second. The intervention was not really a true intervention because, again, this was determining a risk score for the pre-hospital setting and determining how well it matched up with clinical assessment of the clinicians, assessment of the dispatchers, and what happened at the ER. This is the news score. So this is a validated study or a validated score based on all of these parameters that determine how critical the patient is. Basically, it's the higher, or not even just the higher, but the extremes of your score are linked to worse outcomes, or more likely to be critical care, or more likely to require higher level of services. And in the middle is 0, where you have your basically normal. So this is something validated that's been used. It's retrospective. And this is what was the gold standard to compare the model that they created about. So this is basically the questions that they asked. Can machine learning algorithms help triage patients appropriately at any level? So from dispatch to the hospital door, from the time the paramedics and the nurses show up at the doorstep, and even in the ER. And this is one of the first studies that, not one of the first ones, but this is a study that really truly looked at risk scores in the pre-hospital setting rather than the ER setting, because this is already looked at in the ER setting somewhat. Again, comparing the validated news scores to what the nurses triage, and then pre-hospital providers and the risk scores. And then can more patients be triaged in non-ER locations, which they didn't actually look at those patients that were triaged to non-ED locations. So I would argue that this question can't really be answered based on if you're excluding that population. But that's a conversation for at the end. And then the main thing was the priority at dispatch, and the calculated news scores, and did they align? So did you dispatch your, level 1 priority EMS to the call, and was the news score appropriate for that patient? What they looked at outcome-wise from the hospital is who was admitted from the ER to the floor, just a regular floor admission, who was admitted to the ICU or had mortality within 30 days, and then all-cause mortality within 2 days. I'm using 2 screens, so I want to make sure I'm not missing anything in the notes. So predictors for the programming, and this is how they tried to manipulate the machine learning algorithm a little bit. So they used patient demographics. They used operational factors. So trying to control for hour by hour, the month that the call went out, the distance to the ER in a case for acuity, and frequent flyers, whether that was the frequent CHF exacerbation or the frequent, psych patient. Those all kind of came into this and helped define the algorithm to severity and risk category. And then patient factors. This was a little bit harder to define, but again, with the way that their data came in, they said, okay, if they were having symptoms for a certain number of hours, days, that would play into the algorithm as well, and to predict who were the sicker patients. They even mentioned that was a little bit of a limitation, because again, it has to do with charting. It is objective because it's what the patient tells you, but it's a little bit harder to say if that's truly, correlated necessarily. Sometimes it is, and sometimes it's not, at least anecdotally. So the outcomes, so they had over 45,000 records in the training set. So that was the 2016 beginning to the end of 2017, where they took all the data out, created the algorithm, and they tested it with over 23,000. About 44% were excluded because of the criteria, and that was under 18, triaged and released, transported to non-ER settings, multiple patients, and I think there was 1 or 2 other ones. Across the board, all the priorities were admitted, 50%, and that was consistent. And in general, the higher acuity meant higher priority. So this is where it makes a little bit more sense, because a lot of this was like, okay, what are you talking about? So on this bottom graph, you are seeing hospital admission, critical care, and 2-day mortality, the 3 outcomes that they really wanted to measure. And that was, these are all the different scores that they used and what was the validated method. So dispatch priority in pink is about what that's the standard practice. So the EMD was a priority 2 for chest pain, and where they ended up throughout the entire stay for all the records that they looked at. And that was the gold standard. Then they created these different scores. So based on the information that we have at dispatch, can we create the algorithm to be a little bit more sensitive and specific for resource allocation? What about what we get from the ambulance, by the time they show up and the data they get? Can we eliminate the dispatch portion of this? And then what about the news score that we calculate? Does that correlate with what the dispatch priority was? So again, you're seeing that all of them, except for the dispatch priority, are a little bit more sensitive and more specific to determine if the patient's going to be admitted to the hospital, if they're going to require critical care, like an ICU bed, or 2-day mortality. And critical care, again, is all mortality in 30 days, regardless of being admitted to the ICU or not. So the general outcomes are, so dispatch data outperform the news score for admission specifically. So if you dispatch that patient and you did it as a level 2 for chest pain, it was likely to correlate with a news score of a higher priority, and they were both would correlate with an admission. Calculating a retrospective news score would be outperform dispatch for critical care and 2-day mortality, which makes sense. It's validated. It's got the extremes. You're looking at respiratory rate, you're looking at pulse oximeter, you're looking at a few different variables. And all the models, the machine learning models specifically, outpredicted the standard dispatch priority. And then if the ambulance data was included, so you included all of the data plus what they showed up with, then the machine learning outperformed everything. So basically what I could be a little bit wrong again, the article was a little bit hard to determine because it has to do with a lot of these, but essentially all of the models that used machine learning and used this algorithm was able to predict admission, mortality, and ICU level care better than the clinician by themselves or dispatch by themselves, essentially. And this is the data that kind of highlights that. Now, the current is what actually happened. So these are your 2016 to 2017 data, who was transported, what ambulance intervened, what the news score was calculated for those patients, who was admitted in their 2-day mortality. And then hypothetical is if they could rearrange the transport priority and how it worked out. And basically the higher priority that they were able to use by the machine learning algorithm in general correlated with 2-day mortality, admitted patients in critical care. So it's basically just a redistribution of resources based on some of those demographic features, including frequent flyers, the patient level data, the type of call that was coming, where the call was coming from, help determine the priority of dispatch so that you could dispatch the right resources, and with the data that they get helps predict all of that. So it wasn't really a clinical decision tool. It wasn't really, so this is somewhat of a good checklist for it. It was a pre-hospital setting. The patients were representative of those with the problem. I would argue, yes, you're trying to determine if the priority of dispatch, the priority that EMS has, is appropriate for predicting outcomes. It was a retrospective and a not validated model. It was kind of a prediction model. It wasn't really put into clinical practice to truly change anything. It was all hypothetical based on the data that they got moving forward. So it was impact analysis of a previously validated. It was compared to the news score, but it wasn't validated to a prior clinical decision rule. It was not, it was prospective somewhat, but it was not sufficiently long and complete, and the effect was large enough and precise enough. So again, this is not the best checklist for this. I would argue that for the study itself, it's a decent study in the sense that they used a large sum of data. They did a retrospective arm, they trained their algorithm, and then they used it prospectively to determine if their models were correct. The author's conclusion: it's a feasible approach to improve clinician assessment and triage. It can augment dispatch decisions, but it doesn't replace a clinician at bedside. So for the example that they use and that I like to equate to is an allergic reaction may require the highest level of care immediately, but that doesn't necessarily always equate to admission, ICU level care, or 2-day mortality. So you may be able to dispatch a higher level of care, but at the end, that's going to be one of your outliers where that doesn't translate. And there's going to be a few things like this. We see it all the time. We see the patient that I was listening this morning to some of the residents, and there was a patient that came in with a toe laceration to Newark and ended up with a type A dissection. I don't know the details of that case, but things happen, and nothing really right now can replace a clinician, but it can augment the clinician's views. It can help augment dispatch systems to say, okay, well, this is the same type of call that we get for this demographic, this amount of time. We can send this resources, and it could theoretically change how often you have triage to BLS if you're using these types of things at the bedside. It could decrease the amount of cancellations because you're not using those resources. So, it's very much in its infancy, but it's at a systems level may be able to help in that situation. And it may assist in alert systems. A high likelihood of admission. This is something that they do in Sweden, expedited care to the floor. And what they say is, okay, if you know that the patient's going to be admitted based on all of your data, or it's like a 75% chance, then you could have the admitting team at the bedside in the ER. That'll never happen in any of the ERs that I've worked in. Maybe, but I highly doubt it. But still you could go, okay, this is a high risk call. We're going to let the ER know ahead of time, which we kind of already do when the EMS gets there, but now dispatch can go, okay, this is a high likelihood of needing ICU level care based on all of this. And it doesn't have to be necessarily a call to the ER doc or the charge nurse every time, but there's could be an alert system in there so that you can go, okay, well, maybe we should save one of the resus rooms because this might be a bad call, rather than filling it with, a borderline CHF that could probably be fine in a regular tele bed. So again, from a systems level, you could have some moving parts when this is a little bit more refined. Again, limitations. So there's population-based differences. So the population had a higher mortality and admission rate compared to other studies that were performed in the ER. This may be the population that they have. So this might be like comparing the Toms River population, which has a high sick elderly patient population, compared to Irvington, which is a lot, you have your sick patients, but in general, they're younger. So are they, the same type of population? Maybe not. So this is one of the things that they have as their limitations. You're also limited by input data. So, the same biases that you put into a system, there's always an adage that computers are as smart as the things that go into them. So if you put incomplete or, biased data in, you're going to get incomplete or biased data out. And there's no way to fix that at this point without, trying to control for that stuff. It's a single site study, even though they used 2 EDs, they were both part of the same system. And like I had mentioned at the beginning, they exclude triages and alternative destination patients, which I think would be a great study, a great population to study, because if you, especially with ET3 and community paramedicine becoming a big thing right now, the more that you have these patients, downgraded to BLS, we see it, with our own system. You have triage to BLS, and then they show up hypoxic, and then they start coding in the ER within 5 minutes. Or you triage, you get an RMA and they go by private car, and then something happens. Or in the future, when we are able to set up, okay, you're going to bring the intoxicated patient that you've seen 100 times to, the detox center instead of the ER, but they had a head bleed. So I think in order for this to truly capture a good amount of acuity and to assist the clinician, you should see those patients. How many of those alternative destination patients ended up in the ICU, to help determine if you can really offload some of the weight in the ER. So because of that, I don't think it's applicable or generalizable at now. It's very early. Most of these machine learning things are, but it's something to keep on the horizon and keep in mind, because as more data comes out and we're moving to, the HL7 is getting implemented to where we are importing Epic. Once we switch over to Epic and we have EMS charts combining everything, you have all of that data at your bedside, or for you to use, and you can start creating some of these algorithms. And machine learning does not require huge servers. You can have a simple program that sets up and does it for very simple outputs. It's not going to necessarily triage and change the whole game, but it's some way to get interesting data. And so that's why these are the final conclusions. Like I said, FirstNet already uses some prediction models to help with staffing and resource allocation, and flexing up and flexing down based on historical data. It's going to impact everyday care in the future. Maybe not necessarily in the next couple of years, but definitely in the next 5 to 10 years. And like I said, ET3 as a pilot, it's going to become standard of care to some degree. And I might be wrong, but alternative destinations are definitely something that CMS is pushing for, and quality care is something that everybody's pushing for, and they've been pushing for 10 years to penalize readmissions to the hospital. And this may, again, this is not necessarily that case, but if you can use a machine algorithm to say, okay, we're going to dispatch the resources for a community paramedic to these frequent flyers that we know are low risk of high mortality, then that's one way you can implement this. And then applied to the right population, it can change practice. So again, it's a lot of information. It's a lot of, okay, some of it doesn't really make sense, but essentially using historical records, they were able to predict who was going to be the sicker patients and require more resources. And essentially the message is that, you're going to see this more often, and it's going to become a little bit more relevant to all of our practices, I think, in the future. And that's all I have for this part of my hour.
Yeah, so machine learning has been around for at least 10 years, if not more. And the really key is getting the artificial intelligence to understand the little nuances. So you got to feed it a lot of data. And the problem, especially with EMS data, is that, you know, we don't always have the right capture. And that's one of the things that, especially in the quality management area, we talk about all the time. Is like, and unfortunately, it comes down to drop-down menus. You know, for every paramedic EMT out there, you know, hate the drop-down menus, but that's how we get quality data. One of the things in the ER that we always say is that we knew you were coming, we just didn't know who you were. It's the same thing with EMS as well. We can predict, you know, where the resources are going to be needed. We just don't know who the patient is. I remember I was in dispatch a number of years ago. We were trying out some of these new systems, and you know, the system popped up and says, you know, potential cardiac arrest in this parking lot. So we're just like, whatever, you know, nothing was happening. So we sent over one of the units, and lo and behold, cardiac arrest happened. And these are just anecdotal, you know, cases, but you know, that's how good some of these systems are. In the marketing standpoint, you know, you go to a lot of these conferences where they talk about machine learning, and it's not just in EMS, it's not just in emergency. The real driver is in advertisement. You know, I believe it was Target or one of these other companies. You know, they implemented machine learning. So one day, father called the company complaining because suddenly they got sent all this like baby coupons and everything. It's like, why are you sending this to my 16-year-old daughter? And then 5 days later, she tested positive for pregnancy, just based on her behavior, using, you know, the Target card or whatever. They predicted that she was pregnant. So this is how good some of these technologies are. This is the same thing with the cars that drive themselves. And I think this matches with the article about the drones is, you know, where can we deploy these drones? You know, if we can have a drone hovering overhead in that area that, you know, we predict that there's going to be a cardiac arrest or there's going to be some sort of major accident. I think that's the bigger one. And then have like a trauma kit ready to go right there while they're sending in the ambulance or something. That's where some will definitely make a difference. I think we're still a number of years behind. And that's the whole reason why 5 years ago they were talking about self-driving cars, and we still haven't gotten them yet because of the fact that those little tiny details are the issue. Anyone else? Amandeep, Matt?
Yeah, just the only quick comment would be that the fusion of data in from multiple centers is, I think, where you're going to see a lot of machine learning dispatch. You know, the amoebas and things like that have really poor buy-in from a lot of dispatch agencies and staff. Some of the dispatchers and administrators love them. Most of the street providers really don't. Not to say they're not useful, but I think what they're pointing out is that the data and the processing of that data is not there yet. And so certainly, you know, as everybody's pointed out, a technology that has a lot of promise and, you know, like all promising technologies, needs to be refined so that it's actually useful.
Yeah, I echo everything you guys are saying. I mean, I think the biggest utility, to be honest with you, is through dispatch. And there's so many things that you can do with this. And, you know, from a screening perspective to throughput, just getting efficiency to deliver care. You know, it's all in dispatch and through dispatch center that we can really make the greatest impact.
Should I move on to the case?
Yep.
All right. This is not about machine learning. This is a little bit easier, theoretically. Oh, crap. I want to do it the other way. All right, can you see the title?
Yes.
Okay. So this is based off of a case, EMS case. A lot of the details were changed, partly to make it more interesting and not just giving it away initially. But there's no like HIPAA stuff in here, no agencies or anything like that. So are they just intoxicated? Since this is a very common topic, we've talked about it many times before. It's a lot of liability, and you go, oh, that guy's just drunk when it's really a head bleed, or oh, that guy's just drunk when it's really an overdose, or oh, that guy just, you know, anyway, we could keep going on. But that's why the title. So you get a 911 call, and be as interactive as you want, but so there's a 911 call for a 30-year-old unresponsive at home. On arrival, the crew found mom, who's screaming. Patient lives alone. Mom is there to just in the area trying to drop by. Does anybody want to know anything? This is the patient. So you get a little bit of history from mom. Patient's an alcohol drinker, supposedly not daily. He's got a prior GSW to the leg, and he's allergic to Haldol. Seemingly kind of random, but kind of gives you an idea. Okay, he's unresponsive. Why is he unresponsive? So you're a decent medic, EMT, and you get vitals. Heart rate's 140, blood pressure's a little high, he's a little tachypnic, pulse ox is a little low, blood sugar's okay. Is there anything missing from the vitals? So you get a temp and it's 102. Is there anybody that would want to triage to BLS and just say, oh, they're just drunk, or, you know, or they're you know, something else, right? We've kind of seen some things where, you know, you wonder, is this the right case that EMT can handle, or is this a medic case? And, you know, I think we would all argue they're, you know, they're stable-ish, but they're really not. They have hyperdynamic vital signs. So this is their physical exam. They're unresponsive, they're tachycardic, they're warm, they're confused and moaning, they have dry mucosa, and he's got a scalp abrasion. And all the docs know this thing. Matt is a hatter, dry as a bone, kind of gives you a clue as to what's going on, and it's a way to think about these things. It's one of the toxidromes. So before I give away what toxidrome, a differential diagnosis that you can consider with this patient. So he drinks. So is he just drunk? Is he a withdrawal and having an alcohol withdrawal seizure? You know, he's tachycardic, he's hypertensive, he's got a scalp abrasion, but he's warm. Is that something to consider? Is it an opiate overdose? Well, you know, I didn't tell you about his pupils, but, you know, they're not pinpoint, you know, unless he's got like Suboxone or, you know, meperidine or something like that. Is he septic? You know, 30-year-olds can be septic and encephalopathic. Is that something? You know, blood pressure is, again, a little high. Typically you see normal or low, but that's not a, you know, you can see high blood pressure as well. Or is it a toxic or metabolic cause, right? So there's a good differential to have in your head with anybody that you go to that's altered mental status, right? Because not everybody's just drunk or high or, you know, just encephalopathic from a seizure. There was actually a call I went on this morning with the medics that came in as a
Yeah,
17-year-old.
yeah, with the case, someone's confused. Let's say it's not a 30-year-old. Let's say it's an elderly patient. We're talking to people and, they're just like, oh, leave me alone. I don't want to talk to you. Are they confused? This person's mom is there. They're saying, oh, the patient's confused. Or the elderly patient who's 66, plus or minus the history of dementia, who's telling you, I feel fine. They know their name, they know where they are, and they're saying, leave me alone. But they have all these other symptoms. Are they confused or are they not confused? I think we were given lecture last week. We talked about the topic specifically because this happens all the time, where, the family wants the patient to be taken to the hospital. The patient doesn't want to go.
Right. So some more info from the case. You have your differential, you have some vitals, and then the patient starts doing this. You don't have a line yet. So the medics give midazolam 5 milligrams intranasally. It doesn't do anything. The patient's still seizing. And, the med control was called and they said to RSI the patient. So these are the first things you should do, whether there's, obviously easier said than done if they're seizing, but always check a blood sugar. Maybe they're hypoglycemic and that's why they're having seizure-like activity, or maybe they are in DK and that's why they were encephalopathic. You want to start an IV fluids, hook them up to the monitor, get them vitals, and the 12 lead, which will be important in a minute. So patient keeps doing this. They got the 5 of midazolam. Med control says to RSI the patient instead of giving additional doses, which you could argue one way or the other, but you want to get control of the situation. So the patient, in this case, the vitals started trending downward. Blood pressure started to become hypotensive, even though they were initially hypertensive. They couldn't get IV access because obviously the patient is seizing. It's not going to work. There it goes. So, anybody that's dealt with a seizing patient, nurses or otherwise, knows that it's very hard to just hold their arm and get an IV without getting injured or, putting yourself in harm. So it takes multiple people. But the patient was drilled, which, is a valid thing to do in this case. And they attempted RSI. They used ketamine, rocuronium, and then a dose of ketamine for post-sedation. While attempting RSI, patient codes. Now, you have a initially hypertensive, tachycardic, encephalopathic, confused patient that starts seizing and goes quickly into cardiac arrest. Some people are probably wondering what's going on. They were hypotensive before RSI. Should they have gotten push dose pressors? I would argue that that would be appropriate. Even if you don't really know what's going on and they're hypotensive and you're about to intubate them, at least having it as a backup and having it a little bit, case by case basis is appropriate. This may have been one of those cases. Maybe if they got, IM midazolam or another dose of IN midazolam, maybe would have been able to stop the seizing. Sorry about that. But either way, patient goes into cardiac arrest. Could have been inevitable again. And my apologies, they did get fluids before RSI. They got about 500 cc's. So they get ROSC after about a minute, a dose or two of epi and some bicarb. And then they were able to get a 12 lead, and this is their 12 lead. The specific things for this one is obviously tachycardia, and if you look at the QT, it's a little long. It's almost on the P wave. It's not you can't really tell much else. The PR interval looks okay. It's a narrow QRS. Doesn't look like SVT or anything like that. Does anybody have
so fast? So getting a repeat 12 lead once the rate comes down will also help.
Yep. So does anybody have updated differentials as to what this could be? So this is something I got from MDocs. It's it's a table of toxidromes. There's multiple different types. To kind of give you a clue and a mental idea of where to go. So showed up and the patient was tachycardic, hypertensive, had a high temp, dry skin. So that fits a lot of anticholinergic versus sympathomimetic, except then you talk about dry skin, which sympathomimetic doesn't have. So all the med students may know this, the residents, attendings, it's the tox handshake to see if they're wet or not. Basically just feel if they have perspiration or not. Serotonin syndrome is another one where you have very similar features, except not dilated pupils, and they're going to be diaphoretic. So it kind of gets you into a mindset of, okay, it's their altered mental status. These are their vitals. What should I be thinking? Now, we'll talk about treatments in a minute. Does it necessarily change your pre-hospital care? Maybe. In this patient, it did in the actual case. But it's also something to go, okay, well, this is what I can tell the ER when they arrive, or this is what I think is going on, even though I couldn't find any bottles of anything, or maybe they just did a lot of cocaine and now they have a brain bleed or something like that, right? So it's a way to kind of help categorize things. And cholinergic, I'm going to mention, because I'll mention it again later, is going to be the opposite of anticholinergic, obviously. They're going to be most likely bradycardic, they're going to have constricted pupils, they're going to have excess secretions, and they're going to be diaphoretic. So you have both sides of that. Opiates, you're not going to have necessarily the hypertension. You're not going to necessarily have the hyperthermia, that kind of stuff. So this helps kind of determine, oh, they're not just drunk, or maybe they are. Alcohol does cause high blood pressure, tachycardia, especially withdrawals, or they're not just high, or maybe they took some SSRIs or tricyclics or something. So a recap of this patient specifically before I give you away that's what's going on, what the patient ingested and why they're unresponsive. So you have a warm, dry, moaning, unresponsive, confused patient that has status epilepticus and seizures, not unresponsive to medications, despite 1 dose of midazolam. Again, it's still status. Their hypotension is getting worse because their hemodynamics are, they're starting into cardiovascular collapse. They're having worsening respiratory status, and they had ROSC after they were given bicarb. So now is the clue for what the inciting event was. So the patient was found actually to have pink foam come and dried pill bits coming out of the patient's mouth. And if I told you that at the beginning, you kind of know what's going on. The patient took Benadryl. Now, Benadryl we think of as, taking it before we go to sleep or after a night shift. But it's also in, it's used for allergies. We use it all the time for anaphylaxis, right? It's in Tylenol PM, and that brings a whole different toxidrome and toxicity, with Tylenol overdose. It's a very dirty drug. It's a very dangerous drug. My toxicologist in residency, refused to give it to anybody for any reason. And I'm going to just briefly talk about the pharmacology of it to show why it makes sense that the patient presented the way they did: warm, confused, seizures, and into cardiovascular collapse, and why bicarb was important in this story. So it's an antihistamine. It's a general antihistamine. It's supposed to work mainly on H1 receptors, but as it's a first generation antihistamine, it works on all of them. So you have theoretically vasoconstriction, but really you just have decreased capillary permeability. You have sedation. It lowers your seizure threshold. It affects the GI tract. It affects the heart, affects the lungs, affects everywhere. So as an antihistamine, you're getting some sedation, you're getting some vasoconstriction, and you're getting, a lower seizure threshold on top of drying you up a little bit. It's also an anticholinergic or antimuscarinic, and we think of duonebs and ipratropium as a muscarinic antagonist in CHF, or sorry, not CHF, in COPD. So this does the opposite. So this is going to clamp down a little bit. It's going to basically make you dry, urinary retention, fecal retention. It's going to cause tachycardia because it's opposing the M2 receptor. So you're actually going to have unopposed sympathetic stimulation. You're going to have sedation again. You're going to have pupillary dilation. You're going to have just dry everything and vasoconstriction. So it's two things that Benadryl does already. It's also a sodium channel blocker, and I put lidocaine toxicity in it specifically because we kind of all know what lidocaine does from a local anesthetic point of view, and from an antiarrhythmic point of view. It's a sodium channel blocker. So and cocaine is the same. That's why this other picture has cocaine in it. So think of Benadryl doing what cocaine does as a sodium channel blocker, or what lidocaine does as a sodium channel blocker. It can cause change in mental status. It can cause arrhythmias. It causes muscle twitching or tremors. It can cause seizures. It causes a whole lot of CNS and issues. It causes vasoconstriction. So you're having vasoconstriction, sedation, altered mental status in 3 different ways, plus tachycardia and a predisposition to arrhythmias. Also, as a sodium channel blocker, you're causing effects to the heart, right? So you can prolong the QRS, you're prolonging the QT from the action potential, so it's going longer. So you're, like I said, you're predisposing to arrhythmias. Now, a terminal R wave is something that we talk about in TCA overdose, but it's kind of a similar idea, that because TCAs can be anticholinergic and sodium channel blockers in addition to the way they work, and they draw out the QRS and cause this terminal R wave. This is a 12 lead kind of showing it. And I bring this up to have a mental clue of something to think about in the future, and why an EKG is very important in these patients that are undifferentiated altered mental status, because it can clue you in as to potential treatments and as to potentially what's going on. If you have a complete heart block and the patient's bradycardic and they have a history of hypertension, is it a calcium channel blocker overdose? Is it a beta blocker overdose? Is it something like that? So this can kind of clue you in. And I also mentioned this because of the treatments. So specifically, this patient required, every time they got bicarb, they had ROSC. I think they coded 3 or 4 times, if I remember the case correctly. And every time they got bicarb, they would have ROSC. They got some epi, obviously, in that because of the ACLS protocol, but then they got bicarb and they would come back. So historically, specifically with TCA overdoses or sodium channel blockade with a terminal R wave and a prolonged QRS, bicarb until that narrows, right? So this is true for Benadryl overdose too. If you give them bicarb until that QRS narrows, you can protect the heart, and you can kind of help. It doesn't necessarily reverse it, but it helps buffer everything out, so you can give supportive care. If they have a prolonged QT, you can consider magnesium. We carry it in the trucks, we carry it in the ER, then QT prolongation is very common with this. But in general, it's supportive care. If this patient didn't code or need an airway, it would be monitoring fluids, EKGs, called poison control, that kind of stuff. So even EMS, you can do these types of treatments just like we would do the same thing in the ER. Magnesium for this may not necessarily be in your protocols, but med control can help you out. If you have a altered mental status with a prolonged QT, a terminal R wave, it's something that perhaps the docs can, discuss with you. But specifically for this bicarb, especially in an overdose like this. So the last, I think, 2 slides. So what if it was Tylenol, alcohol, antihypertensives, or antidepressants? Nearly the same. And again, I made this a little bit more of a general altered mental status because, we have some patients that come by BLS into the ER that are altered mental status because it was, they're just drunk, or, and Navin mentioned this already, we see it all the time, but they had a head bleed, but they had a toxic overdose. There's things in ALS care that, while you may not necessarily reverse everything, it's important to assess these things so that we're aware, or a reason to call med control, or a reason to call medics if you're just a BLS unit. because maybe they need a 12 lead. Maybe they need Narcan, which I know BLS and police can do. Maybe they need to be paced, right? You need a 12 lead to show that they're in heart block because of a beta blocker overdose. And I had mentioned this before. So cholinergic toxidrome is the opposite of anticholinergic. So our case was an anticholinergic, or sodium channel blocker, and antihistamine, which causes all of this. But there was also a case within the last month or so of an organic phosphate poisoning. And the treatment for that is atropine. It's atropine, atropine, atropine until you can dry up their secretions. So it's in general supportive care, but the treatment is atropine for cholinergic. The treatment for anticholinergic could be bicarb. It could be pacing for calcium channel blockers. So, you know, having just your run-of-the-mill altered mental status involves a little bit of assessment. Now, the majority of overdoses, the majority of these patients that are altered, is it going to necessarily make a difference? Maybe, maybe not. Depends on the age, depends on the vitals, depends on the history. But it's better to just not write off these patients and look for pill bottles, look for supportive information. You know, 20-year-olds can be on antihypertensive. You know, are they out working in the yard, things like that. So there's clues to all of these stories that are important, that could change management, especially in the EMS setting.
And sometimes
That's all I got.
exactly saying like, you know, why did they have this new set of pills on the table and it's empty, but it was filled yesterday? You know, why are there like 100 freaking, you know, bags of fertilizer that's open or something like that? Pool supplies is another thing. Also, if you think about it, you know, it's on-scene clues that we don't get in the ER or even ALS when they intercept. You know, they don't have that on-scene assessment. And, you know, if something's odd, you know, just mention it because sometimes that's the one clue that kind of tells you what's going on with this patient. Now, Amandeep, anything? We'll wrap it up and head over to the regular conference.
Yeah, no additional comments.
I think, you know, this is a good topic. Something to keep in the back of your mind. You know, the relevance in EMS, I guess, you know, I've seen some very rare occasions where you have people in outpatient offices who get an overdose of lidocaine. And when that happens, you know, you just have to be kind of mindful of some of the symptoms. And even in the emergency department, obviously, if we have patients who have like very large lacerations and we're using anesthetics to do that, you know, you can precipitate toxicity. And one of the always kind of telltale signs of someone getting a lidocaine overdose is, you know, the first symptom is going to be some perioral numbness, followed by, you know, seizure-like activity, and then followed by VTAC. So those are things that, you know, you have to kind of, you know, be on the lookout for. And I always say this, like, I mean, you know, if you have that scenario, the first thing you say is someone who's getting lidocaine, perioral numbness, or has a seizure, grab a cart because they're going to code next, and then grab some bicarb. And knowing these antidotes are huge, and being able to pick up on those are huge. So, you know, having that in the back of your mind, knowing anticholinergics especially, Benadryl, you know, surprisingly is such an easy commodity, and you know, it's abused quite a bit. And so we quite often see that. And actually, interestingly enough, in the pediatric world, you see a lot of unintentional overdoses because of the Benadryl's presence in many medications. So very common to see kids who are coming in altered. And a lot of times we presumptively assume that these kids are on drugs or, you know, are taking some other medication, but really they just overdosed on over-the-counter medication and they just didn't know any better. So always things to look out for. And this is why we always recommend, and you know, this is the hallmark of it is fact finding and information gathering when we're pre-hospital and we're going to, you know, package a patient. One of the things that we have to look into is what medications have they have access to, what medications have they taken, so that we can, utilize that in the emergency department and actually collectively look at what all they're possibly could have taken, so we can kind of, have some understanding as well and put that information together as a collective whole. But yeah, it's a good talk. Good case.
All right, I'll see everyone on the next journal club. I'll send out an email when we get a little bit closer. And